Hi, folks. It looks like we have a few people. Everyone's slowly trickling in, so I'm just going to give it another 30 to 45 seconds or so to let everyone enter the webinar. Hi there. If you just joined me, we're just going to wait another few seconds. People are still slowly trickling into the room. All right, it is slowing down, so I'm going to go ahead and get us started. So hello, and thank you for joining us today for STI Outbreak Response, Preparation, Identification, and Intervention, hosted by HCET with presenter Michelle Johnson-Jones. My name is Jordan Greenwald. I'm the Training and Community Engagement Manager at HCET, and I will be moderating the webinar today. I do want to briefly introduce you to healthcare education and training, as we may be new to some of you. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. Next slide, please. This webinar does have closed captions available if you need them, and to enable them on your screen, you will click Live Transcript at the bottom, then click Show Subtitles, and then you can change your settings by clicking Subtitle Settings. Throughout the presentation, we do encourage you to send your questions via the Q&A box, and to submit a question, you'll hover over that main screen, select the Q&A icon at the bottom, and then once you click on it, the Q&A box should appear. To send a question at any time during the presentation, please just send it through this Q&A box, because this ensures that everyone in the webinar can view your question. And please note that you can also send questions anonymously if you would like. We also encourage you to follow us on our various social media accounts to keep up to date with the newest information and future events. You can also view past events on our social media as well. A link to complete an event evaluation will be sent to you following this webinar. Your feedback is greatly appreciated, so please fill that out. Archived presentations and a list of upcoming events can be viewed on our website. And if you have any technical difficulties during this presentation, please contact updates@hcet.org. Nursing contact hours are available for this webinar. In order to receive nursing contact hours, a participant must attend the entire webinar, return the completed participant evaluation, and then complete the nursing contact hour form, which will also be sent to you following this webinar via email. And once you receive that form and complete the webinar, you can send that form, complete the evaluation for the webinar, you can send that form to kbradford@hcet.org. No one with the ability to control content of this activity has a relevant financial relationship to disclose with an ineligible company. And finally, I would like to introduce you to your presenter for today. Michelle Johnson-Jones is an epidemiologist in the Division of STD Prevention at the CDC with 18 years of experience addressing sexually transmitted infections. Specializing in data related to outbreak responses, Michelle uses that experience to create tools for outbreaks and evaluate data before and during outbreak responses. A native of Kokomo, Indiana, Michelle graduated with a bachelor's degree from Creighton University in Omaha, Nebraska. After working in laboratories post-college, she discovered epidemiology, the mix of health and data. As a result, Michelle pursued her MPH from Indiana University, Purdue University at Indianapolis, with an emphasis in epidemiology. She began her work in sexually transmitted diseases with a project for the Indiana Department of Health and was hired by the Arizona Department of Health Services STD program. Then Michelle was hired by the CDC, stationed in Kentucky, and finally moved to the headquarters in Atlanta. Michelle has worked a full range of jobs within STD prevention, including DIS, frontline supervisor, surveillance coordinator, and epidemiologist at the local, state, and federal levels. She looks forward to using her knowledge of outbreak response to help her home states. Without further ado, I will be turning things over to Michelle.
All right, thank you so much. Appreciate it, Jordan. So yeah, this is, for those of you from Indiana, this is a bit of a homecoming for me. So welcome back. Yeah, today I'm going to present on STI outbreak response, the three major steps of preparation, identification, and intervention. This is restating the same thing. We're going to go through them in that order: preparation, identification, and intervention, and then provide some resources. And I will make sure that the resources are available to you, so you don't have to write down the links to any of these. You will get them. I will send them through Jordan to make sure everyone gets access to the resources. All right, let's start with preparation. When we're thinking about outbreaks, we have to consider that we also have rising cases at the same time as we have outbreaks. Currently in the United States, we're seeing a shift in cases of syphilis from what used to be predominantly MSM cases to much more heterosexual transmission of syphilis. And so as we see this shift happening, that is showing us a rise in cases. Because it seems to be very broad and generalized. When we're talking about outbreaks, we're talking about a very small, specific population that has syphilis is the example I'll use mostly here, just kind of dinging around within that sexual network. So you can have a rise in cases at the same time as you have an outbreak, but the approaches to them are differently. So for a rise in cases, that's a much more programmatic approach of, do we need to change our reactor grid? Do we need to deprioritize or reprioritize what we're working on? An outbreak is going to be a concerted effort to really address a very small time and really defined population that is having a surge where we can make a big difference by addressing that outbreak. So the number one thing you will hear over and over is create an outbreak response plan. CDC is going to eventually probably request them from sites. Most jurisdictions already have one. I know HIV also requires jurisdictions to have an outbreak response plan, but that is the basis for all of these. So within your outbreak response plan, this is a really word-heavy slide. You'll need your objectives, your preparedness for it. When are you going to activate a plan? What are the roles and responsibilities of the individuals? Where can we get staffing and resources? How do we deal with data security, because it may not be in the traditional means? What's the communication plan? And who are our partners and our collaborators that we can identify before an outbreak so that we can rely upon them during an outbreak? Then it's more about what's happening in that response. Management structure. Who are we engaging with for the partners? What diseases are we prioritizing and what ones are we deprioritizing? And then the actual investigation, right? How do we know if it's an outbreak, which we'll go over later? How do we verify it? We make a case definition to really establish what we're looking for and describe the population affected. Really look at the data and get out there, implement prevention and control measures, and then summarize the findings. And then those recovery, what you're going to do in the recovery phase post-outbreak, and any appendices you need. This can all vary, but this is a rough outline. So when it comes to STIs, which infections are the important ones? Which ones are you going to be concerned about for outbreak response? Syphilis right now is a priority. It is changing the population it's in. We are seeing outbreaks happening. We have partner services where we can really get in and try and intervene. And the cases aren't so large that we can't handle it. It may be a little overwhelming, but it's not the same amount as chlamydia and gonorrhea. Another one to think about is drug-resistant gonorrhea. I think Indiana also had some where they had to follow up on some gonorrhea cases with high MICs, minimum inhibitory concentrations that were showing concerning levels that certain antibiotics wouldn't work. Investigated, taken care of, follow-up happened, but that is worth it following up on. Novel diseases, not just COVID-19, but there are other things. For example, sometimes neonatal herpes, although it's not a novel disease, it's not a reportable disease. And there are times that neonatal herpes can be something that needs to be investigated as an outbreak. There have been cases out there where during circumcision, Moya will suck the blood off that circumcision cut. And in those cases, when that practitioner had a herpes sore or sometimes asymptomatic, they could pass herpes to the infants. So it's not just the reportable diseases, and it's not always quite everything that's sexually transmitted. We have a broad group here of diseases that STI folks are required to cover. But these new presentations and new diseases are definitely worth following up on. Sometimes it's worth it to think about co-infections, especially some of the hepatitis infections, along with syphilis, travel-related infections, and even lab or abnormalities. So there have been times when there's a mutation, and the laboratory test that we traditionally use doesn't detect this new mutation, like it interrupts what the lab test is looking for. And so it will read as if it's negative, like they're not infected with chlamydia, when in fact they are. It's just the test couldn't pick it up. So there was a case series of this from over in Europe, and they identified it and made a change to the test and were able to figure out what was going on. But these are the things we need to think about and address as an outbreak. But chlamydia and gonorrhea, unless it's drug-resistant gonorrhea, the numbers are just too high to really focus on it. There may be times when you want to. There may be a very specific case that makes sense for an outbreak, but for the most part, that's not what we're looking for when we're looking for outbreaks in STI programs. So part of this preparation is really about the partnerships. These are partnerships that need to be established before an outbreak happens. Make yourselves known in each other's lives way before that so that you can rely on each other in the event of an outbreak. Internally to health departments, there are other infectious disease programs. There's emergency response, who has a lot of resources about setting up outbreak response plans, may even be able to run it. And sometimes there's an advantage because they are not so in the weeds with syphilis or what other disease STI that we're working on, and that they have a little step back approach that they can really help and leverage some resources. And make sure we're partnering with laboratories, not just the public health laboratories, but also other commercial laboratories. Maternal and child health is also a good place, Medicare, vital statistics, all places where these partnerships can help leverage access to data, decision-making, and just other avenues that are opened up by these other programs that have access to other groups in the community. But then external to a health department, the other key elements are other local health departments. They really are the first to see what's going on. Jails and prisons, they're a great place for outreach, and they're also just a great place for just making sure you're in contact with them to follow up what's going on. There are providers that have specialized populations. For example, I worked in Kentucky, and there was one provider who that practice tended to see Spanish-speaking farm workers who were mostly single men. And that was a really good connection to have because it's a small subset population. And so if we're looking for outbreaks, if there's an outbreak in that population, that provider is probably going to see it first. Tribal entities, community champions and organizations, and even universities and colleges where you can also get additional help. And the question is, how do you, after you identify these, how do you maintain relationships and partnerships with these places? I come from a very data biased place. One thing is to provide a data report, either about their jurisdiction, their population, or something you might think is interesting to them, maybe twice a year, and give them data that's a little more tailored to their population so they can see what's going on. There are events you can work on together. There are all kinds of places you can go. Sometimes it's just every time there's a new DIS hired on, making sure they are introduced to that community organization and that their name and face are known. Giving lectures, small little lectures at the university or colleges keeps that going. Also helps promote people's interest in STIs. So we keep that workforce going and people coming on to work in STIs. And big piece I've often seen missed is communication in the preparation stage. So when an outbreak occurs, commonly seen, everyone just kind of starts churning up the communication and the messaging. I think there's a lot of preparation that can be done to really help streamline the process when it's actually needed. So many agencies have limits on what words they will allow people to use. And so having that list of terminology that is approved is key. So women of reproductive age is what has traditionally been used. Now people are leaning towards people capable of becoming pregnant. It's trying to say the same thing, but in gender neutral terms. There are some health departments I've worked with where they are happy to use people capable of becoming pregnant. That is, they're key on that. And I've worked with other ones that say people aren't going to know what that means. We are not there yet. That is not what we're using. We are sticking with women of reproductive age. And so knowing that in advance is very helpful. And it gives you something if you want to push on it, right? You're not doing it in the moment of an outbreak. You are proactively trying to change the language if that's what you want to do. Another example is this MSM versus gay men versus men who self-identify as gay or bisexually, individually or collectively. Like there's some really hard language, right? And then there's very precise language. And communication teams have a lot of thoughts behind this. And so knowing what their thoughts are really is helpful. I put a resource here that you will get later is CDC has come up with a list of preferred terms for select populations, groups, and communities. And it includes everything from, I think what you've more commonly heard, instead of saying, you would say people living with HIV versus he was HIV positive, right? You're shifting everything around. So CDC has some terms that they have and that are set, and there are still more that are in the works that are not quite decided on. So some of these around pregnancy and who can become pregnant, to be more inclusive, is not on that list because I don't think it's settled yet at the CDC level. Really pulling together the previous HANS, or Health Advisory Network, messages, media messages, communication materials that came from previous outbreak responses, or any other interaction that required a HAN. And with those, the suggestions for change based on that previous outbreak. We'll get to at the end, this is a full cycle that once you go through the process of an outbreak response, you're going to review and see what you would do differently. What's important is to just take those changes that people suggested and implement them on the front end. Put them in your outbreak response plan if you need to. Put them with those materials so that if someone else comes along and picks it up, they have all the information based on what was learned the last time. They're not trying to reproduce it or run into the same errors. Another piece for these HANs and these communication is we want to be very careful. It's a hard balance of avoiding stigmatizing while sharing pertinent information that allows everyone to really zone in on who the affected population is. And then people really want action steps. They want to know what they should be doing. It's great to get information to know this is going on. Yes, that's great. But be clear on what you're asking. Are you asking providers to screen more? Are you asking a community organization to spread the word and share education materials? And often putting that up front in these communications is key. Highlighting it, making it stand out, these action steps, so that it's ready to go and people feel empowered and know what is asked of them. Communication approval. Within my agency, it's hard. I've worked in other health departments where it's a long process. It's hard. People are quibbling over the first thing on here, the words that are used, and all the steps that needs to go through and who all has to see it, depending on how publicly it's going to be shared. So having those down is super helpful when it comes to dealing with an outbreak response. And finally, if this is feasible, instructions on how to create a shared mailbox or an internal listserv or a group email address that can really be used to efficiently communicate during outbreak response, so that people are emailing a central place. They are, and it's getting disseminated. That it's not trying to manage a list all the time, because that becomes one of the most frustrating things. Is this person is still on the response, this person is off. How do I, like, oh, I need to add them. Oh, someone hit reply all to this email and suddenly these 5 people are not on it. So finding a more streamlined way to manage that can be really useful. Also, if you have a shared email address that everyone sends it to in events of FOIA, when people are asking for that, you actually have a much easier place to look for the bulk of the communication if someone is requesting that through the Freedom of Information Act. So another piece that I think is underutilized, and I include myself in this, is documentation. There are so many pieces of the jobs that are done and the tasks that are in people's head, that they know what they're doing, they've figured it out, but they are the one who knows it. And we learned post-COVID, I saw, between burnout and programs that changed their pension structure, and DIS who got opportunities to make more money or have more leadership in other programs, that there was a lot of outflow of STI staff post-COVID, and that leaves a big gap. And documentation is the key to helping make that smooth transition. It is, I don't know anyone, no, I know one person who really enjoys documentation. Other than her, I don't know people that enjoy it. And I'm thinking in all kinds of jobs, not just in STIs, not just in public health, but documentation in business is a big piece of it. And I hear complaints about it there, but it's so critical and everyone is doing it or should be doing it. So some of the documentation that can happen is really about job descriptions. What is a surveillance coordinator? You have the job description when they were hired. What about updating it when they were, like, annually, when they come in for their evaluation? Things have shifted, things have changed. But also include those soft skills, because when we're trying to bring in more help during an outbreak response, sometimes it's about finding people with the soft skills, with someone who is very logical if they're in surveillance, someone who I think the DIS are the hardest to replace because they are salespeople. They're trying to sell people on doing partner services. They are a psychologist because or a therapist because they're helping people. They're a social worker. And they have to know the medical information. So when I look at job descriptions and I see a DIS, there's such an array of skills that they need to have to be successful that that person is very hard to replace. But nothing against surveillance staff. I've been surveillance staff. But someone who can read a case definition and apply the logic to it and is very more regimented in that way, absolutely, that is a little bit of an easier person if you need surge to possibly get someone in there with those soft skills. It will also help you when you're trying to write a job description to hire more people and to really identify what you want. Data flow, how data comes in. There are multiple ways data comes in. Understanding the processes that happen within surveillance, within DIS, within supervision. How does that data flow? What decisions are made? Where does it go? Who makes those decisions? Case definitions, and then decisions that are made, including what ideas were rejected. So we don't keep we're trying to reinvent the wheel that we rejected. We're trying to put make a square wheel, and we say, no, we want it to be round. Well, the next set of people come around and they say, ooh, what about a square wheel? Right? Having this documented can save a lot of time and saying, oh, this is why it didn't work. Training materials and a lot of things you have in new employee orientation. Once it's documented, keeping it up is much easier, but creating it the first time is a lot of work. And so, but I will say DIS are very used to this. If you didn't document it, it didn't happen, right? So we need to think of that in other places besides just documenting our interactions with clients and patients, really about what we do on a daily basis. So in summary, in preparation, you want to create a formal outbreak response plan. Documentation is key. Stay in regular communication with partners to maintain the relationship. Document the previous successes and suggestions for change, and then know those internal processes for communication, data management, handling media. All right. So moving on to identification. I think this is a very interesting place for me. This is where a little more of my passion lies. So we're going to walk through some ideas. So first is, you are the company you keep. I think many of us have heard that phrase before. We are most similar to those that we are around. Well, keeping that in mind, think about our syphilis. I'm going to stick with syphilis as an example, but our syphilis investigations. Here is an example of what we know. When we do partner service and we identify cases, we're looking for epi links. And for ease, we'll stick with sex partners. And so these lines connecting two dots are two infected people that were sex partners. Here we have a cluster of 3, and we have a lot of singlets of cases that are not epi-linked to any case. Because all we know are the cases we have identified. But the truth is, we really suspect there's something else going on, that this may be a single network. We just haven't identified a number of people that would have linked several of these singlets together, or linked even more of these cases in a different way. So what we know is very limited, and that's the data we have. So what we suspect is a much fuller picture. And another way to think of that is it is the sexual network that we're trying to identify, right? And I'm going to use these ribbons to show a sexual network. And right, they are 3D, they are interactive. You know, people are interacting with someone else, not just the person next to them that they're having sex with, but you know, there are cross points where people are having additional partners. So some of this, and so for simplicity, I'm just going to break it down into these ribbons. So there are several ways that these sexual networks can interact or be sized. So here are 2 sexual networks with a lot of overlap. You can see where the 2 colors are merging together. There are many touch points. So as we talk through this, we think about disease introduction. So for example, if disease, was introduced on one side, the odds of it going to the other side is high because there are so many points where these 2 sexual networks overlap. There are some networks that have very minimal overlap. So if disease is introduced here on the top one, the green teal one, the odds of it making its way into the lower or purple sexual network is much slower and lower because there is just a single point where they overlap, a single person in this case. There are some very loose networks where they're just, there's not as much overlap, that maybe people are a little more concurrently monogamous, like they are choosing one partner at a time. And then there are some very dense networks where it's like a balled up string, right? There's so many points that are touching. There might even be concurrency where a person is having sex with multiple people together, or like at the same time, like Monday with person A, Tuesday with person B, Wednesday back to person A. And so thinking of disease going through this, you can see how it can move very quickly. So let's use this as an example. Let's say this is a town and these are their sexual networks that are in the town. There's some overlap and there's some separation. And what we think about is if disease was introduced here at this red arrow, it will probably go more slowly through this network because it's a very loose network. But if it does get through the network, then it will probably take off within this red one because it's very dense, and because all 3 of these intersect, that it has a good chance of also going to this teal network. But because these 4 lower ones don't intersect with these top ones, then this should be a closed set of sexual networks, and the disease is not going to be spread within it because it's not been introduced. Now, if we switch to up here and disease is introduced in this very dense network, it's going to move rapidly. And the odds of it getting from this person over to this person is very high because there are so many routes and ways it can get there through these sexual connections, which then increases the odds of it going into this teal one and this yellow network. But again, because it's separate from these lower networks, we wouldn't see disease introduction down here. And this matters for when we are trying to intervene. Right? Like, we always want to work rapidly on outbreak response, but if you have a dense sexual network, you've got to move faster if you're going to stem it. So this is executed through looking at the data. You really want to decide on a data analysis plan in advance, not just, ooh, do we have an outbreak? We should look. So set a regular schedule for reviewing data. And there are different methods out there. We don't advocate for one particular method. People do what works best for them. There are several examples out there. It could be 2 standard deviations above the mean of the last 3 years. It could be all kinds of calculations. It also could depend on geography. I worked in a place where if there was 2 cases that were epi-linked in a rural county, we investigated that as if it was an outbreak and looked into it further. Whereas if it was a major city, the threshold was much higher. And then you want to look at cross sections. It's not, if you're looking at a major urban area, you just can't say, hey, is this county having a rise in cases? Because you're actually looking at a set of sexual networks. And one sexual network could be having an outbreak while the others aren't. But it's much harder to detect when you're looking at a large geography. So breaking it down further can help figure out what sexual networks might be having an outbreak. I put some examples here. You can break it down by geography, not just county level, zip code level, or neighborhood, or there are other things that locally will make a lot more sense. Sex of sex partners, race, ethnicity, risk factors, other co-infections, stages. You know, do we see a big increase in primary and secondary syphilis? But what I want to warn you is when we talk about these sexual networks, these people are connected and they are similar, but it doesn't mean they all look alike or all act alike. So within a single sexual network, you could have people of multiple race ethnicities that maybe inject drugs, or 70% of them inject drugs. The other 30% are partners of people who inject drugs. And so it's, even though I put this list here of what you're looking for, these outbreaks can be really hard to find in these dense areas because it doesn't look uniform, but you are trying to detect any signal you can. So I will say you have these cross sections of what you're looking at. You will get false positives, especially the more intersections and things you look at, the more likely you will get a false positive. So the follow-up step is to examine those oddities, those aberrations, and see if you can dig a little deeper. Were they related cases? Were they epi-linked too, not just there's a rise in this population or this area? Are there other things going on? So we see when screening increases, disease number of cases can also increase, which is a good thing. We're finding the cases. Is it an outbreak? Well, that's actually yet to be determined. but there are other reasons things might be higher. Also, travel plays a part in it. You might have 2 unrelated cases in a rural county, one who just moved here from another state and someone who has been living there a long time. That is not a concern for an outbreak because they are not connected to each other. So we're not looking at a big blossoming rise in cases right then. So in summary, it's complicated. We look at the data, we see what we can do, but it's not perfect. So I think the better way, and the way I have learned about most of the outbreaks I have worked on, is other people, not looking at the data, using the data to back up what other people are seeing. So for one big one is DIS. What trends are they seeing? What cases do they suspect are cases that are connected, but they haven't had them named as partners yet? What else can they, what else is going on? What else are they seeing? So for example, I worked in outbreak where we saw many men of the same age group in a small town were HIV positive, like they were actually getting newly diagnosed with HIV. Even I'm using the terminology wrong today, but they are newly diagnosed with HIV. And they were like, we all had our suspicions of why are we seeing 4 people from this smaller area with this? And then the DIS started talking, and they all started talking about all these people were very linked to one particular church group, is what they called it. It wasn't a physical building or a physical church. It was a church group that they called a church group, and they were all linked to that. And right, so we started, it was that, which never would have shown up in the data, that connection between them, because they weren't naming each other, but we had our suspicions. But the DIS were able to find that connection. Then that made us say, yes, now we're seeing an outbreak. Now we know where to intervene. And I really think having meetings that combine the DIS, the EPI staff, and the surveillance staff is critical. The DIS have chalk talks, bringing EPI and surveillance in there every so often to hear, I think will help identify some of these outbreaks a little bit earlier. Local health departments, like they are, I think they see a smaller nugget than a state health department. And so I think local health departments are key to identifying outbreaks sooner and really seeing that connection and knowing the people in the population there. Providers, I talked about the provider in Kentucky that saw a very specialized subset of the population. And so when there was an increase in syphilis in that provider, they contacted us. And it made sense because that is a very connected and small population, and that provider was seeing many of them, and so noticed this outbreak sooner. And prisons and jails. I really enjoy working with prisons and staying in communication with them and visiting. And then they are getting a broad look at like a state as a whole or in a county as a whole, but they're seeing a much smaller slice. So sometimes they can make connections that get lost in the overwhelming amount of data that is seen at the county level or at the state level. So really, once you think you have an outbreak, you've seen this aberration, or more likely someone has alerted you to it and said, hey, I'm concerned, we're seeing a lot of cases in this population. The goal is to define the population as narrowly as possible. As I said, not everyone looks the same in a sexual network, so that can be very hard to do. But you're going to have the best outcomes if you can really narrow the outcome or narrow the population as much as possible. So you're concentrating resources on the right group where we can knock out syphilis in this instance. You want to document the steps leading up to determining it was an outbreak. Who notified you that this was a concern? What date did they notify you? What do we know about the situation? When did we call an outbreak? Things of that nature. Make sure those are documented. And then my suggestion is create just a 1 to 2 page summary of the data that really describes why you think this is an outbreak. And that is so key in being able to pass that along to some of the decision makers to really help let people know what's going on, give a little more evidence that you know what you're talking about and that there is great concern. And if you use figures, people can really take in that data a little bit faster and go, whoa, this is a big change. Now I see it. And that gets you a lot of support. I think a little bit faster if you can make that summary of the data. So in summary, we want to maintain communication with the people who identify an outbreak first. And for me, secondarily, is examining the data to see if there are aberrations that are truly outbreaks, but it takes digging. Refine the description of the affected population to be as specific as possible, and then create a summary of the data describing the outbreak. And the final step is intervention. So when there's an outbreak, you can activate your response plan. Now, you don't have to send out the whole thing. You don't have to make it a massive one. You need to scale it appropriately for the outbreak of concern. If this is the very beginning of an outbreak in a loose network, you can probably do with a little less activation. If it is a dense network and a rapid rise and it's clearly defined, like that may take a fuller response because it may take more resources to intervene. And the goal is to rapidly intervene because as disease is spreading through the sexual network, if it's not taken care of fast enough, reinfections start to happen and you've kind of not undone, you've definitely made progress, but you've changed, you haven't made as many steps forward as you were hoping for. So this isn't realistic, but the ideal situation would be take everyone from that affected and at-risk population and really try and get them all tested and treated on the same day, right? Not feasible, but that's the ideal. And then we move back from there for our actual ability and what we can actually do. But rapidly intervening is the key. I suggest good brainstorming sessions that involve a lot of people and a lot of listening and really map out what's going on. So what do we know about that sexual network? How can we better define? How can we refine that definition? Where can we intervene? Like, what are all the points we can, kind of with the next one? What are the medical touch points and the social touch points for the affected group? And not all of them will turn into something where we can actually intervene, but it's really good to map it out and lay it all out there so that we can see what we're dealing with and prioritize. What are the barriers for the partners we haven't found, right? Like knowing who we think we're missing and why we think we're missing them can be really informative as to how we approach trying to knock down the disease in a sexual network. And be creative. Just really listen to each other. So in an intervention, there are a lot of action steps and they all depend on what is most appropriate for that particular outbreak. You want to create a case definition, again, that narrowly defines the affected population. You want to have your management structure for the disease, for the response. You want to figure out what resources and how much and for how long you're going to reallocate resources. You can set up screening events and community education and medical education. This one is key and I think often forgotten. notify your partners about this, especially the ones that maybe brought the information to you. Keep them in the loop early, not just when you need them to do a screening event, but when you are standing up an outbreak response. Data communication tools. If you're going to do a study design, we don't do it as often in STIs, but it's absolutely possible to do a more epi style study. And then the outcome of the interventions, there are three main ones that I think of. So one, the outbreak is over. It was done. It got knocked down. Success. That really happened. Two is that we're just too depleted to continue this. That we put in everything we could, and we can't continue to allocate that many resources. We aren't making the impact we are. That at some point it needs to be called. And that's a really hard decision. And I don't have broad advice for it. It really, though, needs to be a conversation throughout the outbreak response, almost on a weekly basis of, all right, should we continue this? Is this working? Is this worth it? And just really having that talk, because at some point you have to say, either the outbreak is over or we can't continue it. And then that disease is now endemic in that population, that it is widespread, and that is going to be what it is, and that is where it is, and we will switch back to our regular resources and just keep going and with what we can. And then there's recovery. Again, trying to highlight the points that I think are often forgotten. So in recovery, so after and at the end of the outbreak response, really taking care of staff. Lives were interrupted, people had additional stresses, they relocated, they worked with different populations. There's a lot of things going on. Those staff need to be taken care of and given time to both recover, and when they switch back to their regular jobs, there is going to be a period of adjustment again, and reorienting and getting back into the flow of where they were before. Really summarize the outbreak metrics. I think a key one is how many person hours were worked, because we're working on this. We want to do the outbreak response. We want to knock this down. But again, at some point we have to call it. So knowing how much we have invested in it matters. Budgets are not unlimited. And my suggestion is, if you're doing up a report, you can translate those person hours into dollars. So you take like the average salary of a person and for a year, and like say you had 300 person hours on it, and they make $20 an hour. I already forgot my number up front. 300, we'll call it 300 person hours and $20 an hour. Then we're really looking at, it only cost us oh my gosh, I just messed up on my math. Right, so you get $1, I'm just gonna restart. We get a dollar amount for it. And that is, I think it helps people reframe what it takes to address an outbreak. And it's often worth it, but it's not at zero cost. We also have missed opportunities, but administration, I find, tends to understand dollars more than they understand person hours or missed opportunities. Summarize the number of cases and contacts and all the events that were executed, all the screening events, all the education events, outreach. Really document all that went on. Document those suggestions and make changes while the ideas are fresh. We talked about this in the very beginning about adjust a HON for the next time, or at least mark what you would do differently so that it's better for the next time. Evaluate how the outbreak response went. Additionally, update that outbreak response plan with the lessons learned and the successes. Monitor that population post-intervention. whether the outbreak was knocked out or the response was stopped, really it's about following up and still monitoring. How many screenings, how many provider visits were there? How did it compare to pre-outbreak? What is the number and description of the cases? Did it shift? Is it the same? And then think about long-term changes that can be implemented. Are there policy changes that need to be made? You know, I've worked with an outbreak where DIS could not transport clients in their car to get to treatment. But it was also a place that had no public transport, very limited ride share. The population affected didn't have much money. And so there were all these barriers to people getting themselves to treatment. And the DIS not being able to transport was also a big barrier. So in order to make a change, we really had to work on what policies needed to be changed from there. What is that transportation policy? Can we get it changed permanently or semi-permanently to really implement this? Case prioritization. Do we need to rethink how we're prioritizing cases now that the outbreak is over? And the one that I'm always an advocate for that doesn't always happen is hiring. How does this show us where our gaps are, where we need more people? What can we do differently and really hire people to really fill those gaps? So here are the resources. Again, I will make sure they get to these. If you are at a jurisdiction funded by CDC, talk to your project officer. They can really help put you in touch with things. CDC has an outbreak response resource website. We even have an outbreak email. Again, with this group email thing, it goes to one email address. So you guys just have to learn one while we can respond internally depending on who is working on outbreaks. Stories from the field about outbreak response. CSTE also has outbreak, syphilis specifically, outbreak detection guidance. And HIV has a very different approach. They have more resources, but they have their cluster in outbreak detection and response. And really promoting that CDC website that I mentioned before. Here are the sections that are in the CDC STI Outbreak Response resources, really a plan guidance, activities, what to do for GC drug resistance, health alert templates so you're not recreating them, case report forms for disseminated gonorrhea, much more information about drug-resistant gonorrhea. And with that, I will end. I see the question about who makes the decision of outbreak versus increasing cases, DIS. My experience, it is usually a management level decision. And that is why I think summarizing so much of the data into a very simple format really helps make that call, because I think many people have input. The DIS should have input. The surveillance staff should have input, but really that call, in my experience, has been much more on a management level.
Thank you, Michelle. It looks like a question came in via the Q&A box as well. I can read it for you. If a jurisdiction hypothetically runs out of money or resources to respond to an outbreak, do you still consider the outbreak over? How do you effectively scale back efforts without seeming to leave a community when they are still in need?
Yeah, there are two subtle differences. So there's an outbreak being over. I should have been more clear. And there's the outbreak response not continuing. And so the outbreak may not be over, but the response may need to taper or end. I think that the population that's affected should play into how much you put into it. We need to serve underserved populations. Like, we can't just abandon because they're hard. But time and money is an issue. So there are some external resources. This is where the idea of pulling in MPH students from a university can be hopefully useful. Trying to get people in that can maybe do the work a little longer. It is a difficult call. Actually, in my experience, people don't want to call it over. It actually continues for a very long time, and people are more resistant to saying we need to slowly back out of this. They're more likely to continue and say, we need to keep going, we need to keep going. So it really is a hard balancing decision. And again, just like calling it an outbreak, it's often made at a management level, and they have a lot more thoughts about the resources. And so that's why tracking resources matter, because also the next time you do an outbreak, you have a comparison of like, oh, we spent 400 person hours on this one. Look, this one, we were highly successful and we spent 1,000 person hours, right? So maybe we should invest more or keep going, or, hey, that wasn't successful. We need to think about it differently.
Thank you, Michelle. I also want to let folks know if anyone has a question that they'd rather ask out loud. If you raise your hand, I can unmute you so that you can talk, but I'll just give it a few more seconds if anyone has any other questions for Michelle.
And I want to promote Indiana, is the Southern Indiana outbreak that happened a few years ago. One of the things that impressed me most of that was the dashboard that really kept everyone up to date on what was happening for that specific outbreak. How many partners there were, how many cases were still open, how many were infected, what were those risk factors. Having that dashboard kept everyone in the loop, and I got to see it, and it was so impressive. And so that communication was just top notch.
Thank you for that. You know, there's probably some folks in this room who are, or in this webinar who are familiar.
Yeah.
I'm not seeing any other questions come through, but if you think of something later, Michelle did put her contact information up there. She'll make sure to send me those resources, and we'll make sure that the slides get to you as well. I did just see an anonymous question come through, so I'll pause. This question is, if a jurisdiction is hesitant to announce a possible outbreak due to stigma or lack of initial funding, etc., is there any sort of chain of command that the local people seeing the outbreak can move up if the management does not participate?
That is a very good question. Okay, there are two things going on. So one, I have worked with jurisdictions where it's an outbreak. They know it's an outbreak, but they don't want to use the word outbreak because of the stigma, because of politics. There are other things going on. So there is a way around that of you can work on something and not officially call it an outbreak internally, even though that may be what you guys all are thinking and acting upon. But that chain of command for local people, seeing that, I think documentation is key, right? This is the theme of today, is there are a few people you can contact at the state health department that might listen to you. So you can go to an epi, you can go to a surveillance person, you can also talk to your DIS, and you can go to the program manager. And if you really document what's going on, I think you'll have more success. I sat as an epi in one of the places, and I would often get the call of like, hey, we're seeing this, and then we would dig in, and I would have to take it to my manager And I would gather the evidence, right, and try and show that I do think it's a problem that needs to happen. So the little bit of evidence you can gather on your end to really show it helps. And I don't know how else to go outside of that management. Again, if you're going to make a document, I suggest you make a separate document that is a PDF version of it. You can also paste the same information in the email, but by having a separate PDF, people are more likely to share it, in my opinion, that they can attach it to something, they can print it out, and it becomes much more useful.
Thank you.
All right.
Awesome. I'm not seeing any other questions. So thank you all so much for joining. This webinar will be uploaded to our YouTube channel in the next few days. Thank you, Michelle, for this great information. Really appreciate it. I'll follow up with you via email. But looks like I can give you all another 9 minutes back in your day. Hope you enjoy it, and we'll see you next time. Thanks.